So tell you a little bit about our experience at FDNY. I started working um, at FDNY on September 11th, 2001, interestingly enough. And at that time, we had a smoking prevalence in the department of 27.4%, which was actually more than the entire state of New York. Now, because of a number of factors, including having a very robust tobacco treatment program, we're actually less than 4% now, while the state of New York has also decreased, but not as much, down to just under 13%. So I always love this slide. I hope you can see my pointer. Here you see this is actually a right lung field. That is a lung cancer right there. And it is unusual on this CAT scan to see, or on any CAT scan, to see the cause of this lung cancer. Can anybody make out what this is? This is, here's a hint, it is distal from the shirt. In this gentleman's shirt pocket, you see a lighter in face, as well as a bunch of these circular things are actually his cigarettes. It's unusual that you find that. About 1 in 10 smokers develop lung cancer. When a patient asks me, why is it only 1 out of 10? Unfortunately, the answer is they usually die of heart disease first. But about 1/3 of all cancers are caused by tobacco. Non-neoplastic respiratory diseases, the most common is, as it relates to the tobacco user, COPD, about 85%, 1/3 of all cardiovascular disease, and a wide range of miscellaneous medical problems, fertility, pregnancy issues, bone density loss, dental health, delayed wound healing, DM, diabetes mellitus, wide range of conditions relating to inflammation and decreased immune response, RA, and of course, erectile dysfunction. My point here is that whatever condition you or your platform or your device is treating, odds are you have a large number of smokers in that population. Same thing true with psychiatric challenges. The average prevalence of, excuse me for that. The average prevalence for tobacco is, again, about 20%. Not so if you have any one of these psychiatric challenges. It is virtually impossible to find somebody who is an alcoholic who doesn't smoke, for example. It is very uncommon to find anybody with major depression or experiencing a psychotic disorder who doesn't smoke. So again, if your focus is on a psychiatric tool or platform, odds are the people that you are seeing also smoke. I might also add parenthetically, most alcoholics do not die of their alcoholism. They die from tobacco-related disease. Same thing with schizophrenics. Most schizophrenics die from a tobacco-related disease. And the psychiatrically challenged smoke more than the average American. I find this statistic, every time I read it, quite remarkable. 46% of all cigarettes sold in the United States are bought by somebody with a current psychiatric disorder. Despite that, those with psychiatric challenges are ready to quit. You just need to reach out to them. So what we have with the IntelliQuit My Nicotine Test is a chronic disease management platform that allows accurate medication titration. It's one of the reasons why at FDNY we have a quit rate of 70%. Until relatively recently, nicotine and nicotine metabolite assays were expensive, inconvenient, and time-consuming, and that made point-of-care testing impractical. We've been able to overcome all those barriers. Our program is, and technology is FDA cleared and CLIA waived. We utilize what's called computer vision and neural network architecture to enable precise quantification of the nicotine metabolites at the point of care. So the clinician or the tobacco consumer gets an answer within 15 minutes. And there were pre-existing healthcare codes, CPT and HCPCS codes associated with the procedure of about $70 to $110 for each test. So hopefully that this will drive clinicians to engage tobacco treatment with much greater gusto, especially because you will actually know how people are doing biochemically. And indeed, nicotine testing is the new standard of care, as defined by, for example, the American College of Chest Physicians Tobacco Treatment Toolkit. Now, you might think, well, why not just count the number of cigarettes that the smoker is engaged in? And that's true. Counting cigarettes is an important data point, but in and of itself, it's inadequate and biochemically inaccurate. This is a seminal study that was performed by Neil Benowitz at UC San Francisco. And here he took people who smoked on average about 35 cigarettes a day and put them in an environment, actually it was the ward of a hospital, where they could only smoke 5. When they were smoking their normal amount of cigarettes, they were pulling out about 1 milligram of nicotine per cigarette. When you put them in this forced reduction environment, that increased to 3 milligrams per cigarette. It tripled. You can vary and increase the amount of nicotine that's pulled out of any cigarette simply by changing the way it's smoked. That's why testing is so important. Most people think a light cigarette is just a light cigarette. There's no such thing. The only time a light cigarette is not a light cigarette is actually when it's smoked. And if you take a look here, this comes to us also from Richard Hurt at the Mayo Clinic. You can see a microscopic image of ventilation holes. And here on the so-called light cigarette, you actually see 2. Well, this creates a situation where the actual smoke is diluted. If you ever examined your patient's cigarettes where they put the filter in their mouth, if the stain looks like this bullet point, as you see here on the left, they are smoking a light cigarette as a light cigarette. Odds are they are not. Odds are the stain is diffuse. And that means that that light cigarette is not really a light cigarette. Again, there is no such thing as a light cigarette because people cover up ventilation holes. Most people think a cigarette is a rod of tobacco with a piece of cotton at the end. It's actually a finely designed drug delivery system. The tobacco industry has measured where people put the cigarettes in their mouth, where they hold it with their fingers, so that those ventilation holes are actually covered. I actually have had patients who cover them up intentionally. So we allow chronic disease medication titration and better dosing with these FDA-approved medications, of which we have 7, is accomplished by measuring the baseline nicotine levels while the individual is smoking or vaping or using smokeless tobacco, and then titrating the medications to those amounts. Think of it as if somebody was losing weight, what's the first thing you do? You measure them. You measure their weight. And then you measure them as they engage in the weight loss or exercise program so that you can see how they're doing. That's what we're doing. Think of it as a weight scale for nicotine. And studies show titrating medications is inversely correlated with withdrawal symptoms. That is, as you more effectively titrate medications, withdrawal symptoms go down and quit rates go up. And this is demonstrated by this study by also Benowitz and Sachs. They took smokers and they measured their baseline nicotine levels and then broke them down into quartiles, anywhere from a 0% replacement to 100% replacement. We also had 0 to 50 and 50 to 100% replacement. And perhaps not surprisingly, the greater the percentage of nicotine replacement, the greater the success rate in quitting. By the way, most people aren't aware of this, but the largest nicotine patch, 21, originally it was 22 milligrams with the ProStep Letter patch, only about 33% had 100% nicotine replacement on just one 21 milligram patch. Same thing is true with bupropion, which was originally on the market for tobacco as Zyban. And here you see that as the individual cut down, their cotinine levels also cut down. This is a study that actually I suggested and ran with GlaxoSmithKline, and you can see that very nicely here. Same thing with varenicline, otherwise known as Chantix. Measuring nicotine metabolites actually shows how the patient is progressing, and cotinine was actually reduced with varenicline or Chantix in unmotivated to quit schizophrenic smokers. We're proud that My Nicotine Test is used by these prestigious institutions. And indeed, testing, both point of care, either in the office or remotely, increases quit rates. Even for those who continue to smoke, it reduces consumption because you're actually able to see the effects of your clinical intervention, whether it be Chantix or bupropion or nicotine gum, patches, what have you. So the IntelliQuit mobile app provides point-of-care total nicotine equivalent assays in 15 minutes. It's agnostic and it works with any device, medication, or program. We also provide counseling, and we are going to be associating with a number of other platforms to help folks stop behaviorally. IntelliQuit age treatment planning, whether the individual is planning on stopping abruptly, all at once, or what's called a reduction to cessation, a cutting down approach. Medication titration assesses that biochemical reduction in consumption and abstinence, and again, increases quit rates. So significant insurance reimbursement drives significant revenues, and it is our hope that more healthcare professionals will become actively involved in tobacco treatment. This is an example of the revenues that are associated with both digital healthcare as it relates to tobacco treatment, and for that matter, in office. So here is our test kit. Hope you can see where I'm pointing. That's mailed up to patients. It's 3 easy steps. You set up the test tube and color chart like shown here. You drop the test strip into the urine. You take a picture. After it runs for 15 minutes, the app times those 15 minutes. It's lightweight, mailable. It's inexpensive. It can be mailed anywhere in the United States for $8.85, thereby enabling remote patient monitoring. Here are some of the tobacco withdrawal symptoms that people experience when they try to stop. I mention that because a number of products and platforms out there measure these symptoms directly and indirectly. For example, a reduction in heart rate of 8 to 12 beats a minute is a good signal for tobacco withdrawal. It means that medication has to be titrated more aggressively if we're talking about nicotine replacement. Most people don't use the nicotine replacement medications enough, and they discontinue them too soon. This is one platform, SmokeBeat, that offers a wide range of parameters, including heart rate. And of course, there are a number of smartphone APIs that quantify both exercise, mood, sleep, weight, all of which are related to tobacco and tobacco withdrawal. I already mentioned the drop in heart rate of 8 to 12 beats a minute. Weight gain itself also signals tobacco withdrawal. We can treat weight gain in tobacco withdrawal by simply increasing the amount of medication that an individual is using. This is a mobile game that we put together with colleagues at the American College of Chest Physicians. And while there's no sound, I'd like to play it for you if I can. So this is the Stop Smoking Tobacco Pirates, and it's educational in that you're able to ask questions, as you see here. Your doctor may not prescribe bupropion, Zyban, if, and the answer is if you have epilepsy. And for answering the questions right at various game breaks, you get more points. What do you do with the points? Well, among other things, you can upgrade your gum that you can use to then kill the tobacco pirate zombies. And here you see we are shooting them, And these are minions. You kill the minions until the big, what's called the boss, comes down, and you get points, and you're very cool if you win. About to see the boss come down now. We have a variety of different bosses. And the music is pretty cool. It's very piratey. Reminds me of Pirates of the Caribbean. And here's the boss coming down, carrying a cigar, and hopefully we'll get him in time. Oh no, he's getting too close. Oh no, oh no. And boom, boom, we're able to get him. So patients seem to like this, and it's a distraction technique, and that's great. There's also a study that shows that by killing representations of tobacco, you actually increase quit rates independently of medication and independently of measuring nicotine. Imagine if the game, as nice as it is, was actually on the level of Fortnite or some of the really high-end games. I think we would get tremendous amount of patient engagement. And the key, as it relates to digital health, as everybody knows, is patient engagement. Whoops, next slide. So, in summary, similar to any chronic disease, my nicotine test, total nicotine equivalence, aids in treatment planning and medication titration. It assesses biochemical reduction in consumption and eventual abstinence. Baseline measurements and then what we call adaptive treatment protocols are implemented based on changing clinical findings, patient preferences, and clinician input over the course of treatment, increasing quit rates and medically appropriate revenues. Again, regardless of what condition you're treating, odds are, especially because smokers are medical frequent flyers, and so many folks with psychiatric challenges smoke, odds are you can benefit by also engaging the tobacco dependent in your populations. We are actively looking for vendor colleagues. I mentioned some of the platforms that we're interested in. So whether it be heart rate or weight control, all of that relates to the ability to ensure a high level of clinical success. Feel free to contact me at my email or my mobile if you think we're a good fit for you. And that being said, while I can't see the questions, I'm happy to answer any questions that anybody may have. Thank you so much for your time. Remember, your patients are yearning to breathe tobacco-free.
Thanks, Matt. That was a really great presentation. And
Hi, Heather, I can see you.
oh, hold on one second. I'm getting
Yes,
feedback
really
from.
good. Thank you.
That was a great presentation, and I really appreciate that. We don't have any questions. Well, actually, you know what? We do have one question from Tracy here. It says, did you explore any partnerships with pharmaceutical companies? Would be interesting to hear about why or why not. I'm assuming maybe top of mind would be Pfizer.
Sure.
Their work.
So actually, I am on Pfizer's Chantix Speakers Bureau. Chantix has lost what's called loss of They have what's called loss of exclusivity. They've lost the patent because the medication's been out for 20 years. And as such, because of that, while I used to have at least one talk a week somewhere in the United States, that hasn't happened in a while because of the loss of exclusivity. So I have talked with them, but because they don't have any medications currently in the pipeline, and they weren't sure what to do with whether they would be making their own generic and selling it or partnering with somebody. That was all up in the air. Also, they had, I don't know how much inside baseball you want to get, but they did have an issue with nitrosamines in some of the batches, and they voluntarily, Pfizer voluntarily withdrew Chantix. So there's a company that's based in Florida that's importing a Chantix generic called Apo Chantix. So yes, the simple answer is yes, I have looked at that.
Yeah, it's an interesting comment though that when a branded molecule goes off off patent, that the pharmaceutical manufacturer may not be as motivated to partner on a digital therapeutic or
Sure.
digital diagnostic like yours.
I,
Um,
I understand it. It is disappointing.
yeah, yeah. Um, One question, and I think that's the only other question from the audience at this time. And we've got just a few more minutes before we go to the next panel. One question that I had, so trying to tease out your business model, it looks like you're facilitating remote patient monitoring. Is that the primary business model that you've taken to the market?
So we have two verticals.
Mhm,
We have a healthcare professional vertical, which includes clinical and research,
mhm,
and we have a tobacco consumer model. We've just launched the tobacco consumer model, so that the tobacco user can get the test, him or herself, and we can hook them up with either one of our clinicians or their own to examine the result and hopefully do something with it. I mean, it's
mhm.
great to have a number, but the value in having the number of total nicotine equivalents, which by the way we measure in nanomoles per milliliter, it's once you have that number, hopefully you do something with it, and hopefully you say, oh, okay, maybe that explains why one patch didn't work, and let me talk to my clinician about doing something about it. So hope that answers your question. So we do have two verticals.
Yeah, makes sense. And how's your experience been since the previous two panels or discussions were focused on reimbursement? How's your experience been in discussions directly with payers and approaching that market?
So everything that we do has CPT codes associated
Mhm.
with it. We didn't have to reinvent the wheel, and that made our life much easier.
Yeah, yeah, that was kind of the Livongo model that they built their foundation on existing codes, and that's
Yeah,
I think that's a really smart way to get in where you can get in.
I do think it's interesting that CMS and CMMI have instituted a whole network of remote patient monitoring platforms, which is rather generic. They haven't said, oh, you can only measure heart rate or you can only measure weight. They pretty much left it up to the individual vendor.
Mhm.
And I think we're going to be seeing a lot more parameters measured in the future.
Sure. Makes a lot of sense. Well, thanks so much for a really engaging conversation and presentation. I'm sure the audience learned quite a bit, as did I.